And with that, I will hand it over to Dr. Lauren Lee. Thanks, y'all. So Dr. Lauren Lee, I have had the pleasure of working with her on planning these Mpox trainings from the get-go. So she's been a co-lead of the clinician outreach team along with myself and Safri. She is a senior guidance writer for the VDH Health Information team. So she is just an expert at so many things. She got her education starting at Williams College, then got her medical degree at Washington University School of Medicine in St. Louis. She did her residency at UCLA Medical Center and got her master's of public health and epidemiology at University of California, Berkeley. She previously worked as a medical epidemiologist in communicable diseases at the state and local health departments in California. And she's been the subject matter expert for various infectious diseases, including several respiratory, foodborne, and fungal infections. So it's my pleasure to introduce to you again, Dr. Lauren Lee.
Thank you so much. It's really a pleasure to be here this morning, and I'm so glad that we had so many people come out. I know this is quite a bit of a drive for some folks, and we appreciate you being here today. So I'm going to start with an overview and some background on Mpox, and then we'll move on to talk about the epidemiology of the 2022 Mpox outbreak. Next, I'll discuss ways providers can collaborate with public health, and then I'll conclude by sharing a couple of resources. So let's start with some background on Mpox. Mpox is a rash illness caused by the monkeypox virus, which is an orthopox virus. It belongs to the same group of viruses as smallpox, and it's a zoonotic infection, meaning that it can spread between animals and humans. Before the current 2022 Mpox outbreak, Mpox was rare in the United States. Symptoms of Mpox are similar to smallpox symptoms, but they are milder. And the type of Mpox that we've seen in this outbreak is rarely fatal. More than 99% of people who get this form of disease are likely to survive. And Mpox is not related to chickenpox, even though they do have similar names. So Mpox was first discovered in 1958 when there were 2 outbreaks in Denmark of pox-like disease in monkeys that were being kept for research. The specific animal reservoir for Mpox is not known, but African rodents and non-human primates might harbor the virus and infect people. The first human case of Mpox was noted in 1970 in the Democratic Republic of the Congo during a time of intensified efforts to eliminate smallpox. Monkeypox virus is a DNA virus in the genus Orthopox virus. This genus also includes variola virus, which is the virus that causes smallpox, vaccinia virus, which is the virus used in the smallpox vaccine, and cowpox virus. The virus has 2 distinct clades, clade 1 and 2. They were renamed by WHO experts in August 2022 so that the names would be in line with current best naming practices. Clade 1 is the former Central Africa or Congo Basin clade, and this clade can cause more severe disease with a case fatality rate as high as 10%. It spreads more easily from person to person, and clade 1 is classified as a select agent. Clade 2 has been identified in the current outbreak. It's the former West African clade, and historically this clade has caused less severe disease. It is not classified as a select agent. And clade 2 consists of 2 subclades, 2A and 2B, and clade 2B is the one that's been largely circulating in the current outbreak. Now, in recent years, the epidemiology of Mpox has been changing. Before the 2022 outbreak, Mpox had been reported in people in several Central African countries, like the Democratic Republic of the Congo, Central African Republic, and Republic of Congo due to clade 1 virus, and in Western African countries, like Nigeria and Sierra Leone, due to clade 2 virus. And in these older reports, human cases were reported mostly from rural forested areas in Central and Western African countries, or in countries with cases related to migration or travel, or in people who had been exposed to infected mammals. And since 2014, the annual number of cases has been increasing in Africa. And this reemergence of Mpox might be due to a combination of factors, including environmental and ecological changes, human or animal movement, the end of routine smallpox vaccination since smallpox was eradicated in 1980, improvements in detection of disease or diagnosis, as well as genetic changes in the virus. From 2018 to 2021, human cases were reported from 6 African countries, and DRC and Nigeria reported the most cases of clade 1 and clade 2 virus, respectively. Now let's transition and talk about Mpox cases here in the US. So cases in people outside of Africa had been linked to international travel or imported animals, but these reports were not common. In 2003, there was an outbreak of 47 Mpox cases from 6 Midwestern states. And all of the people infected with Mpox in this outbreak became ill after having contact with pet prairie dogs. And the pets had been infected after being housed near imported small mammals from Ghana. This was the first time that human Mpox was reported outside of Africa. The investigation found that no cases were caused exclusively by person-to-person contact. And there were no additional reports of Mpox cases in the US until 2021, when 2 travel-associated cases were reported. Both of those case patients had traveled to Nigeria, and CDC and state health departments did investigations and found no additional cases. Next, we'll move on to discuss the current 2022 multi-country outbreak. So in early May 2022, UK health officials announced a confirmed Mpox case in a person returning from Nigeria. Additional Mpox cases were identified in the UK, and some occurred in people who hadn't traveled to an endemic area or had a known epidemiologic link to other cases. The number of Mpox cases rapidly increased and expanded to other countries. And it was noted that cases were occurring primarily in men who have sex with men. The first US case was reported on May 17, 2022, in a Massachusetts resident. And on May 23rd, CDC launched an emergency response that emphasized surveillance, testing, medical countermeasures, and education. Additional cases were reported in the US, and the first presumptive Virginia case was reported on May 26, and it was confirmed by CDC the following day. Cases to date have been reported in all 50 states, Washington, D.C., and Puerto Rico, and all cases have been from clade 2, specifically clade 2B. WHO declared the outbreak was a public health emergency of international concern on July 23, 2022, meaning that it was an extraordinary event that posed a public health threat to other nations through the spread of virus and required a more coordinated international response. And that WHO declaration ended on May 11, 2023. The 2022 Mpox outbreak has been unprecedented with its worldwide spread and emergence of cases in countries that had never reported Mpox before. It was the first time that there was sustained person-to-person transmission, primarily spread through sexual contact. And this figure shows the distribution of Mpox cases across the world. The orange dots represent countries that have not historically had Mpox, and the blue dots represent those countries that have historically reported Mpox. Larger dots, like the one shown over the US, indicate a greater number of cases reported from that country. As of December 27, 2023, more than 92,000 cases have been reported from 116 countries, with a total of 171 deaths. This figure shows the epi curve by month for the cases from July through December 2023. And as of that date, the majority of cases in the past 6 months were from the Western Pacific region, represented in this figure in green, followed by the region of Americas in blue and the European region in red. 96% of the cases with available data are males with a median age of 34 years. Males 18 to 44 years old make up 79% of the reported cases. And sexual encounter was the most commonly reported transmission event. For cases with this information available, 85% identified as men who have sex with men. And 52% of Mpox infections were in people with HIV, but these data were not available for the majority of cases. Now, during this outbreak, the US has had the most Mpox cases of any country, with more than 31,000 cases across all 50 states, Washington, D.C., and Puerto Rico, and 56 deaths, with 2 of these deaths reported in Virginia. This map shows U.S. Mpox cases by state, with darker shades representing states with more cases and lighter shades representing states with fewer cases. The hardest hit states have been California, New York, Texas, Florida, and Georgia, and Virginia ranks 13th. There have been 580 cases reported to date in Virginia. In the U.S., the total number of new Mpox cases reported has been trending downward since late August 2022, but there is variation in trends based on state and region. CDC does continue to urge health departments and clinicians and the public to remain vigilant, institute appropriate infection prevention and control measures, and notify public health authorities of suspected cases to reduce disease spread. The epi curve in the top right shows all U.S. Mpox cases, and there is that distinctive peak in cases that occurred in the summer of 2022. In the center, we see all of the cases that were reported in 2023, which are the blue bars, and the 7-day moving average of reported cases, which is the orange line. The average number of new cases has fallen from more than 450 a day in August 22 to 4 a day as of December 2023. In the spring and summer of 2023, 2 jurisdictions, Chicago and then Los Angeles, reported an uptick in cases. And several other U.S. jurisdictions, including San Francisco, San Diego, and Oregon, have also reported smaller increases in cases. And these increases in cases in multiple locations serve as a reminder that this outbreak is not over, and we must continue the work to prevent Mpox transmission. This figure shows U.S. cases by age and gender. You can see the overwhelming majority of U.S. cases are in men, represented in the figure in dark blue, and most cases are within the age range of 21 through 55 years. And this figure shows distribution of U.S. cases by race and ethnicity. So in the early stages of the outbreak, cases were occurring primarily in non-Hispanic white men, seen in the figure in dark blue. But as the outbreak progressed, we saw an increasing number of cases in non-Hispanic, Black, or African American people, seen in the figure in orange, and Latino or Hispanic people, seen here in the figure in purple. Disparities have been observed in this outbreak as Mpox has disproportionately affected racial and ethnic minority groups. And when we look at overall race and ethnicity data in the US, we see a nearly equal distribution of cases, so that about a third are occurring in patients who identify as Black or African American, 1/3 in people who identify as Hispanic or Latino, and 1/3 in people who identify as white. Last May, CDC authors published a summary of the domestic Mpox response so far. They described the epidemiology of US cases as well as the public health response. And the authors reported that the majority of cases were occurring in adult men who have sex with men and in people aged 21 through 55 years. Now, similar to what was seen globally, here in the US, the outbreak was also disproportionately affecting people with HIV, and 38% of cases were in people with HIV. And as I've mentioned, health disparities have been seen among racial and ethnic minority groups. Black and Hispanic people have been disproportionately affected by Mpox infection. And the majority of deaths were in Black people as well. And even further, 94% of people who died were immunocompromised because of HIV infection that was poorly controlled. And these data highlight that there's overlap between Mpox and HIV infections, and both epidemics are interacting negatively with each other. It shows the importance of integrating Mpox into routine HIV and other STI care. And these data also demonstrate there has to be a focus on equity when addressing Mpox prevention, education, and access to vaccines and treatment. Now let's take a look at some of the data in Virginia. This figure shows Virginia's epidemic curve, and data are incomplete and are subject to change for the most recent weeks, and that's why the right portion of the curve is shaded in gray. As of February 6th, there have been 580 confirmed cases, 32 hospitalizations, and 2 deaths. Based on the epidemic curve, newly reported cases peaked during the week of August 7th to 13th, 2022, with an overall downward trend since then. Most of the cases have been reported in the northern region, followed by eastern and central. and Southwest and Northwest regions have reported the fewest numbers of cases. Now, in 2023, there were 11 sporadic Mpox cases in Virginia, and in 2024, there have been 3 cases. But there is a concerning small increase here in Virginia since November 2023, with 5 cases occurring over 4 of 5 regions. The most recent case was reported in the week ending January 29th. And among these 5 recent Mpox patients, 2 have been hospitalized, 3 were co-infected with HIV, and only 1 was previously vaccinated. The next few figures focus on Virginia data from 2022 through 2023. This figure shows Virginia cases by sex. The majority of cases in Virginia have been in males. And this figure shows cases by age group. Cases have been predominantly in middle age groups. Most cases were in adults in the age range of 20 through 39 years. And this figure shows cases by race and ethnicity. Blacks make up the majority of cases, followed by whites and then Latinos. So VDH has taken action to contain this outbreak as quickly as possible, and this slide illustrates several of those actions. VDH asks healthcare providers to immediately report suspected cases of Mpox to the local health department, even if testing is being done by a commercial laboratory. VDH investigates all reported suspect cases and facilitates state testing at the state lab, DCLS, if indicated. Close contacts are identified by the LHD and monitored, and the LHD also provides counseling to close contacts about post-exposure prophylaxis or vaccine, and the importance of quickly seeking care if they develop symptoms. And lastly, wastewater testing for monkeypox virus has been performed in Virginia. The average incubation period for Mpox has been 5 to 6 days, but can range anywhere from 3 to 17 days. Mpox spreads when there's close contact with lesions, body fluids, large respiratory droplets or secretions, such as during prolonged face-to-face contact, or contact with contaminated materials such as bedding or towels. And while many Mpox cases so far have been in people who identify as gay, bisexual, or other men who have sex with men, anyone can get and spread Mpox through close contact. Most of the spread in the current outbreak has been from close, personal, often skin-to-skin contact, including sexual encounters, with another person who has Mpox. But there have been some cases in households, heterosexual sexual contact, and cases that have resulted from sharp injuries, such as from a needle or scalpel. Now, I know Dr. Brennan will be discussing the clinical presentation of Mpox, so I won't spend a lot of time on this slide. I will just highlight that the presentation of Mpox symptoms has been different in the 2022 outbreak compared with what was seen in previous classic Mpox reports. Rash in the current outbreak has frequently been located on mucosal areas, including the genitals, in and around the anus, and in the mouth. And we've also seen rash lesions that are localized to one area of the body, and rash lesions have not always been in the same stage of development. And I know Dr. Brennan will also be discussing HIV and Mpox in more detail. I will just remind everyone that in the current outbreak, 38% of people diagnosed with Mpox have been co-infected with HIV. And most reported cases of severe Mpox have been in people living with untreated HIV. They had low CD4 counts and substantial immunosuppression. So CDC has made several recommendations to providers that are listed here, but highlights include if people have suspected Mpox and they're sexually active, make sure to test for HIV and other STIs, as well as assess for other immunocompromising conditions. Consider treatment with TPOXX and encourage patients to enroll in the STOMP trial, which is a trial evaluating TPOXX effectiveness. It's important to optimize immune function and consider consultation with the CDC Mpox response team. They're available by email or by phone. This slide summarizes some of the infection prevention and control measures for patients with Mpox. If patients are isolating at home, it's recommended that they're isolated in a room, preferably separated from others if possible. You want to try and limit exposure to pets and other people. Don't share potentially contaminated items. Avoid activities that could spread lesion material, and routinely clean and disinfect commonly touched surfaces and items. In the hospital, you want to isolate the patient in a single room with a dedicated bathroom. Staff should be using PPE to include gown, gloves, N95 respirator, and eye protection. You want to limit patient movement unless it's needed for medical care. And if a patient does leave the room, they should wear a mask and cover lesions. And then staff should avoid activities that could spread lesion material, such as shaking laundry. And while gay, bisexual, and other men who have sex with men make up the majority of cases in the current outbreak, I want to emphasize anyone, regardless of sexual orientation or gender identity, who has been in close personal contact with someone who has Mpox is at risk. And there are several prevention measures to take to prevent Mpox infection. And I know Dr. Bufobani will be talking more in detail about Jynneos vaccination, but I do just want to highlight Jynneos is safe and effective. It can be given before exposure to Mpox or as post-exposure prophylaxis or PEP. In terms of timing, PEP with Jynneos is ideally given within 4 days after exposure to prevent infection or reduce its severity. Other ways to prevent infection include avoiding skin-to-skin contact with people that have a rash that looks like monkeypox virus rash. And if you're planning to attend a gathering where you might be in close proximity to others, consider the risk. Having multiple or anonymous sex partners can increase your chances of getting Mpox. So temporary behavior changes like limiting numbers of sex partners may reduce exposure. And lastly, wash hands frequently or use an alcohol-based sanitizer. So let's summarize where we are with the current Mpox outbreak. As I've mentioned, case numbers have declined since peaking in August 2022, and this is likely due to a combination of immunity, both natural and vaccine-induced, as well as changes in behavior. And despite this decrease in cases, public health does continue to monitor Mpox trends and ensure people have access to both vaccines and treatment. And since spring 2023, there have been 2 large clusters of Mpox cases in Chicago and LA, as well as smaller increases in other jurisdictions. And Virginia has had a small increase recently. And again, these increases highlight that the outbreak is not over. The focus currently is on vaccination of individuals at increased risk of Mpox, especially in advance of events where people might engage in activities that put them at increased risk. And 2-dose Jynneos vaccine is recommended for those at risk. Now, on November 23rd, WHO released a report about an ongoing Mpox outbreak in the Democratic Republic of Congo, or DRC. And this was notable for several reasons. First, it's an extremely large outbreak with over 14,000 clinically diagnosed cases and 688 deaths since January 1st, 2023. And cases have been identified in new areas, including large urban areas. And second, the DRC outbreak is caused by a different clade. It's caused by clade 1. And as I mentioned, there are 2 main clades of this virus, clade 1 and clade 2. The 2022 global outbreak has primarily been fueled by clade 2, specifically subclade 2b, but the outbreak in DRC is caused by clade 1. And this clade 1 virus can cause more severe illness and spread more easily from person to person than clade 2. And third, this was the first time clade 1 virus has been documented to spread by sexual contact, including among men who have sex with men. And other reasons the situation are concerning is that there is stigma against the LGBTQ+ community in DRC and limited or no access to testing, treatment, and Jynneos vaccination. And this may make it harder to contain the spread. In terms of infection control, including specimen handling and waste management, clade 1 Mpox virus is classified as a category A infectious agent, and it requires more stringent practices than clade 2. Now, the good news is, so far, we don't expect the performance of diagnostic tests, vaccines, and treatment to be different between clade 1 and clade 2. And overall, WHO does assess risk for the general population in neighboring countries and for gay men, bisexual men, and other men who have sex with men and sex workers as a moderate risk. Now, CDC is closely monitoring the situation in DRC, and to date, there have been no cases of clade 1 Mpox identified here in the US. And the risk of clade 1 in the US is considered to be low at this time based on the available information that we have. CDC did publish a health advisory back in December just to ensure that clinicians are aware of the possibility of clade 1 Mpox in people who have had recent travel to DRC. So if suspected Mpox cases travel to DRC in the 21 days before illness onset, for diagnostic testing, it's recommended to follow regulations for Category B infectious substances, collected detailed travel and sexual health history, contact the local health department to rapidly report the suspected case, and coordinate clade-specific testing through DCLS. And it's important to ensure DCLS approval before shipment of specimens. DCLS is currently validating a clade-specific Mpox test, but until that test is available, specimens will be shipped to DCLS and then on to CDC for clade testing. We also ask providers remember to swab multiple lesions and collect 2 swabs per lesion. And for waste management in patients who have traveled to DRC, you want to consider the clinical picture and contact the LHD to discuss specifics on how to manage waste. Now I want to highlight some of the ways providers can collaborate with public health during this ongoing Mpox response. So while cases and news coverage have decreased substantially, Mpox is still spreading and risk remains. So we ask providers to keep Mpox on their radar while they're evaluating patients and continue to promote vaccination, education, and increasing awareness. We have numerous educational materials available on the VDH and CDC websites. And we also encourage providers to integrate Mpox into HIV and STI clinics and include Mpox on your sexual health checklist. Jynneos vaccine is safe and effective, and it's the best tool we have to protect people at risk and stop the spread of Mpox. And we need to continue outreach and education to the populations who are most affected. Now, vaccine coverage does vary greatly between jurisdictions. CDC put out an MMWR last year that found, despite administration of over 1 million vaccine doses, only 23% of the at-risk population has been fully vaccinated. And here in Virginia, 19% of those at risk have been fully vaccinated, and 28% have received 1 dose. So we still have a ways to go to close that vaccination coverage gap. And if you're a provider and you're not administering the Jynneos vaccine, please consider doing so. We have instructions available to enroll as a provider on our VDH website. If it's not possible to give vaccine in your clinic, please refer people to CDC's Mpox vaccine locator. And lastly, VDH has quite a bit of vaccine vials that are set to expire at the end of this year. So now is a great time to start planning those vaccine clinics, collaborate with your community partners, and coordinate outreach events so that we can use this existing vaccine to protect people at risk. If you suspect Mpox, be sure to collect that detailed sexual, social, and travel history for the 21 days before symptom onset. Test for Mpox regardless if the patient has a history of Mpox infection or vaccination. There have been reports of patients getting Mpox more than once, though this is not common. And there have also been reports of patients getting Mpox after having been vaccinated. And remember, when testing a patient for Mpox, keep in mind to test all sexually active patients for HIV as well as other STIs because concurrent infections are possible. And as a reminder, if a patient traveled to DRC in the 21 days before symptom onset, those specimens should be sent to state lab so they can be forwarded to CDC for clade-specific testing. Now, if the patient did not have recent travel to DRC, those specimens can be sent to a commercial lab for testing. Providers must notify the local health department immediately if a patient is suspected to have Mpox. The online LHD locator can be used to find the appropriate health department. And please encourage patients with Mpox to cooperate with the health department to facilitate timely follow-up and vaccination of close contacts. Here are a few things that providers can do for managing patients with Mpox. Consider consultation with CDC for questions about patient management, particularly if a patient has severe infection. We also encourage you to speak to your patients about participating in the STOMP trial. It's a NIAID-sponsored trial studying the effectiveness of TPOXX in patients with Mpox. And patients can enroll in the STOMP trial even if they do not have severe Mpox or are at risk of severe Mpox. These are a few ways providers can stay connected to public health. They can sign up online for VDH healthcare professional newsletters, CDC COCA updates, and CDC HAN updates. We have a lot of information on Mpox available on the VDH Mpox web pages. And we have one last Mpox training coming up on February 14th in Chesapeake. So please encourage your colleagues to attend that last training. This slide lists some of the VDH resources that are available, and I'd like to highlight the last bullets on this slide. We have printed Mpox materials. You can request them by completing one of the red cap surveys. There's one survey for LHDs and one for non-LHDs. So these are our take-home messages. In general, the risk of Mpox infection for most people is low. The current Mpox outbreak has been declining substantially since it peaked in August 2022, but sporadic cases and some clusters continue to occur in the US. And Virginia has had a small increase in reported cases since November 2023. In the current outbreak, most people with Mpox have reported close, sustained skin-to-skin contact, including sexual contact with other people. And the current focus is on awareness, education, and vaccination for people at risk for Mpox. We ask that people keep Mpox in mind when evaluating patients, especially if they have a diffuse or localized rash. Incorporate Mpox into routine STI and HIV care. Keep in touch with the LHD to report suspected cases, and stay up to date on information from VDH and CDC. And lastly, I did just want to tell you about a recent grant that VDH applied for and received. So in 2023, CDC announced Mpox funding opportunity for jurisdictions that was called the Public Health Crisis Response Cooperative Agreement. And VDH applied for and received this funding this past March. And the money covers work activities from January 2023 to January 2025. And the purpose of this funding is to assist jurisdictions in responding to the remaining cases of Mpox, prevent future outbreaks by increasing vaccine availability, demand, and uptake, specifically among the populations who are recommended to receive vaccine, and strengthening capabilities to prepare for and respond to the remaining cases of Mpox. Central Office established a working group for this grant response, and the group reorganized last July to expand breadth and depth across teams. So I know this is a very busy slide, but I just want to highlight some of the grant activities. We have 4 key components that are highlighted here. So one is to increasing vaccination coverage and uptake and accessibility. And that involves increasing education, so making sure eligible people know where to get vaccinated using the Mpox vaccine locator tool. Ensuring vaccine is available and administered in HIV and sexual health clinics. Expanding partnerships with comprehensive harm reduction clinics. For our communication strategy, we partnered with Kaiser Family Foundation to launch an Mpox testing and vaccination campaign, and it's been targeting the MSM, transgender, and gender non-binary communities, and it's been running on multiple platforms, including YouTube, Google Display Network, Google Search, dating apps, and Meta. And in addition to developing and maintaining targeted, culturally appropriate educational materials that include translations, we're also printing materials for our LHDs and community partners for Pride and other events, as well as staying active on social media. We're sustaining outreach and education in the community. We've been engaging with CBOs, gotten involved in Pride and other events, and we are planning 3 teletown hall meetings to solicit feedback from community members. And for clinician outreach, we've shared Mpox updates and newsletters. We've developed these in-person workshops, and we've given multiple updates at multiple meetings. And lastly, we want to ensure timely case and cluster investigation and surveillance. We're making sure we're collecting complete information on cases, making sure surveillance and vaccination data are linked, monitoring the data closely, and developing regular surveillance reports. And lastly, DCLS is making sure test kits are available, and they've been enhancing their test capacity. And that's all I have for you today. I want to thank you again for all of the work that you're doing in the Mpox response, and I'm happy to answer a few questions.